This very important hearing. My name is Dr. Ruth Haskins. I practice obstetrics and gynecology in Folsom, California, and I have a very small but busy practice not far from here. I have served this Sacramento community since 1993, after completing 12 years of active duty service as an Air Force physician. In addition to delivering babies and performing gynecologic surgery, I have been involved my entire professional career in public health education and in health advocacy. I'm currently a member of the Board of Trustees for the California Medical Association, and I'm here to speak as a practicing physician who cares for Medi-Cal patients. Our state's abysmally low provider reimbursement rates are having a direct impact on children and families throughout California. Hospitals, clinics, dentists, pharmacists, physicians, even healthcare insurers all agree that chronic underfunding of the Medi-Cal program remains one of the biggest challenges in healthcare. And sadly, evidence for this underfunding is manifested in many ways. Under the old fee-for-service model, where physicians billed the state for each procedure or service provided, it was easier to compare our state's Medicaid rates and demonstrate easily the inadequacy of those payments. For example, for the remaining 2 million people who still receive Medi-Cal services under that fee-for-service system, our rates here in California are fourth lowest in the country. However, with a shift to the Medi-Cal managed care, the state has essentially privatized the delivery of Medi-Cal through capitation rates paid to health plans without ensuring that access to care is maintained. In June, the state auditor released a troubling report outlining a number of problems with Medi-Cal managed care plan networks and potential barriers for patients to access care in a timely manner. There's no doubt among us physicians that the low rates that are paid to managed care plans, that's what's impacting their ability to retain an adequate network of providers. Doctors' offices simply can't stay open without setting low limits on the number of Medi-Cal patients that we can serve. Patients who have Medi-Cal are having severe problems finding doctors who are willing to see them. Reimbursement rates prohibit physicians from being able to accept the numbers that we would like to without risking losing our practices altogether. These patients lacking their preventive health care and early treatment turn up in emergency rooms, as was just stated, in advanced medical crisis, costing the state much more money in the long run. Pregnant Medi-Cal patients who are unable to get early prenatal care have a measurably higher rate of preterm births and other complications. For every dollar spent on prenatal care, that's about $7 that's saved in neonatal care. This is money that could have been saved by adequately funding Medi-Cal, maintaining provider networks, and getting these patients established with California physicians. It's difficult for us to recruit new doctors into California. It's difficult for us to keep our new grads practicing in this state when they see the low reimbursement rates that Medi-Cal provides. This is not a problem that's unique to California. Earlier this summer, the Federal Center for Medicare and Medicaid Services released a set of draft rules that focus on Medicaid managed care plan registration and rate development. We view this as an acknowledgement by the federal government that access problems persist throughout the country, and increasing provider rates needs to be part of the discussion. To that end, we are eternally grateful to the governor for calling this special session to tackle this vexing issue of Medi-Cal funding. We urge you and your colleagues to make the most of this unique opportunity. The MCO tax is obviously of critical importance to the Medi-Cal program. This is set to expire next year, and the CMA believes that the revenue generated by this MCO tax, matched at the federal level, is an important funding stream that should be renewed. We fear that failure to renew this tax would mean reverting back to the years of devastating cuts to the Medi-Cal program that impact millions of Californians. We're hopeful that the legislature will use this opportunity to look for additional revenue sources to strengthen the Medi-Cal program. CMA is now part of a broad coalition of labor, provider, and public health organizations committed to raising California's tobacco tax. This would have the dual purpose of decreasing smoking rates while raising additional revenue for Medi-Cal provider rates. We strongly urge this committee and the legislature to look at funding solutions like the tobacco tax as you deliberate how to adequately fund the Medi-Cal program. In conclusion, I want to thank Chairman Bonta and the members of this committee for their work this year. I can say with great confidence that California physicians want to care for this population. We need a partner in this endeavor. Please help us care for the over 12 million patients that need our Medi-Cal services. Let's please fully fund Medi-Cal.
Thank you, Dr. Haskins. Mr. South.
Chair and Member Sean South on behalf of the California Primary Care Association. I first want to thank the chair for his leadership, along with Senator Hernandez and their leadership of finding a comprehensive solution through what was AB 366 and SB 243. We really felt like that got to the problem. It dealt with the money that was owed, that had been cut during the worst years of our state. It continued the provider rate bump for primary care, which is essential to keep those folks as that frontline service. And then it also ensured that rates were adequate for the rest of the provider community. So we saw that as the overall solution. We know that we have a long way to go, but we agree that that is where we need to go. I stand here today not because on behalf of my members, because the vast majority of my members do not benefit from any of those proposals. I'm here because we deal with our 5.6 million patients each year, and our members are constantly telling me they can't find specialists. They can't find folks to provide the next level of care for their patients. And it's difficult because you're talking about a group of folks that got into the healthcare business because nobody else was providing care to those populations, whether they be rural, whether they be urban. There was nothing there at the time. So they started a health center. And they provide a vast majority of behavioral health, dental services, everything that they can under their federal mandate, they do. But we don't have control over what goes on beyond our doors. And specialty care is the biggest problem that is created. And the rates are essentially the problem. It always amazes me in this debate that everything in our society is based on what somebody can get paid for something, and that incentivizes people to do things. And when we talk about Medi-Cal, we expect doctors to just, out of the largesse or out of the goodness of their heart, to just take the rates and continue to participate in the system. And then when they don't drop out, the state says, well, look, there's plenty of people that will continue to take these low rates so we can continue to keep them low. The reality is that we can't expect doctors, because of the goodness of their heart, to continue to participate in a system that they can't afford to participate in. I mean, we've seen the growth of the ACA. You have more patients now in covered California. You have more patients in Medi-Cal competing for the limited time that a physician has. And the reality is that you can only see so many patients that you lose money on in any week and keep your practice open. So from our perspective, the rates have to be dealt with, and we really think that's the key problem. We do agree that there are some oversight issues. There was the state auditor's report. We do agree that the state has a role in making sure that the networks are adequate. But we also agree that if you don't give the health plans the dollars that they need in order to create those networks, they'll never be adequate. So just in closing, we stand with the We Care for California Coalition. It's one of the broadest based coalitions I've ever been involved in. CMA is at the table, the hospitals, SEIU, all the folks that care for these patients and really are concerned about the Medi-Cal system. We stand together because we know that the system needs an infusion of money. We know that we're also dedicated to figuring out how to do that, whether that's a tobacco tax, whether that's a new MCO tax, whatever it takes to make it happen, because the Medi-Cal system has to work for these patients. We can't give them a card and tell them you have insurance and not give them the same access that all of us enjoy. It's not appropriate, and it's truly it's almost disrespectful to this population to tell them that they now have this access when it really doesn't exist. So with that, I will end. Thank you.
Thank you, Mr. South. Ms. Pittman.
Good afternoon, Brianna Pittman with the California Dental Association. Thank you, Chair and members, for allowing me to be here and to providing the opportunity to share with you the experience of our member dentists who are serving the Medi-Cal population. Over the past several months, Medi-Cal has gotten some much needed attention, and several legislative hearings have shed light on the deficiencies in the program that our members have known about for years. And the lack of investment in the dental system of care in Medi-Cal has really resulted in a system that's in crisis and is unable to meet the needs of California's most vulnerable population. As outlined in the state auditor's audit last fall of the Medi-Cal program, more than half of the kids in the program were unable to get even a basic or routine preventive visit. annually. And based on some preliminary data that we've seen in 2014 utilization, we think that those numbers are even worse, with only 25% of the children in the program getting any care. And really, this indicates that the access to care crisis is getting worse, and that it's not keeping, access is not keeping pace with the enrollment that's gone up, as has been previously mentioned, substantially. And we really do think that to address the deficiencies in this complicated program, it's not just about rates. Rates are important, but it's not just about rates. We talk about it as a three-legged stool. There are reimbursement rates, there's the provider network engagement, and then there's the administrative burdens of actually providing care in the system. And as we deal with these, one of the things we're really excited about is Dr. Jay Kumar, who's recently come on board as this California's dental director, started this month, is going to be putting together a state oral health plan. So we really look at that as a great opportunity to look at, not just oral health throughout the state, but really in the Medi-Cal program. And while Medi-Cal is really a small fraction of the entire Medi-Cal program, oral health has a tremendous impact on beneficiaries' overall health. More children suffer from dental disease in the state than asthma, and more school days are missed because of dental issues than any other reason. It's really impossible for adults without teeth to get a job, and so we really see dental as very key to overall health and economic well-being. And regarding provider rates, which I think is probably the first and most important leg of that stool, the 10% rate cut that was just passed in the budget we think is a really important step. Really appreciate the legislature and the governor for passing that. But we think that it really just undid the injustice of the cut in the first place. We know that California's rates are at the bottom of the barrel nationwide. And a report that came out from DHCS on rates just this past month in July demonstrates that there's much more work that needs to be done. The review showed that there's been a 77% increase in adults in the program and a 44% increase in children, while at the same time the provider network in Medi-Cal has dropped by 15%. So they're going in opposite directions, and access is only getting worse. And the review also found that in 2014, California's Medi-Cal rates were, for the 25 most common Medi-Cal services, were well below those in other large states like New York, Texas, and Florida. And we're only 31% of the national average for commercial insurance. And in the December audit, highlighted that the rates to providers are, for the top 10 kid services, are 35% of the national average. And they sort of highlighted for the first time that rates really are connected to access. So we think that the state needs to take every opportunity to identify and implement program improvements and targeted rate increases that can boost provider participation and increase access to care, especially for preventive services for Medi-Cal's youngest beneficiaries. And to make these improvements real, we need to first avoid creating a hole in the Medi-Cal budget with the loss of the MCO tax. And second, we need to invest additional state dollars in the program. On the provider network, the state needs to have accurate information on its provider network and to simplify the enrollment process. It's been documented in prior hearings that the referral list of Medi-Cal providers is woefully out of date. They need to be able to determine who in the network, which providers are active, who's taking new patients, and how many visits of Medi-Cal they're taking, to be able to see what is the actual access that's out there, because we really have no idea. We have some idea about how many providers are there, but we really have no idea how many visits are available to the patients that needs to be seen. And enrollment is also an issue. The enrollment and recertification process is a huge barrier that can dissuade provider participation. It currently takes many hours, lengthy paper application, over 40 pages of attachments, and we've heard stories of re-enrollments that have taken several months, up to a year. And this is just something that sort of further burdens providers who want to participate in the system and are getting paid very little to do so. And the third leg of the stool is the administrative ease of the system. And right now, what providers have to go through to be reimbursed for the care that they're providing is exceptionally cumbersome and difficult. There's extensive paperwork and documentation that's required by the department. There are rules that just don't exist in the commercial market, which make it difficult for dentists to incorporate Medi-Cal into their regular practice. And we hear from our members that there's ambiguous criteria and inconsistent treatment authorization that make it difficult to provide care. So in conclusion, we have a system of care that provides services to less than half of the children and the people who are eligible for services. And it's clear that we have a serious problem that needs multiple strategies to address it. We think it'll take program improvements like streamlining the enrollment process and the administrative burdens facing providers. And we also think that there's significant evidence that the low provider rates are part of the access crisis. So we encourage additional revenues to increase rates, and we suggest pursuing targeted prevention services and services to young kids as cost efficient in the long run. So we look forward to working with you on this committee, the full legislature, through the special session and beyond to begin addressing these serious issues. Thank you.
Thank you, Ms. Pittman. Thank you to all of our panelists for your presentations. Members, any questions or comments? Mr. Levine.
Yeah, thank you for those great presentations. I introduced an MCO tax proposal during an extraordinary session because I feel the urgency to provide the care that your members are trying to provide for people. And I know that we've had a huge challenge on the reimbursement rates, trying to get the level of funding that we need. But what really frightens me is having to cut over $1 billion of funding and the services that represents, which we will have to do if we don't resolve this now. When you're thinking about what those cuts look like, what are you seeing? What would that mean in reduced services? Where would you anticipate those cuts to come from? I know you're not the administration, but where would your fears be as to where would they go, and how would that affect those lives?
I'll start first. The way the hospital rates are structured and looking at the number of beneficiaries in the Medi-Cal program and the services they rely on, OB services are extremely important for this population, and they're already pretty scarce. When you look up in Northern California, and when you look between Redding and the Oregon border, I think there's one OB provider. I would hate to see that hospital stop providing OB services because they couldn't attract providers to provide those services. I don't know what those women would do. Of greater concern, though, I already raised the really big concern that we've been seeing over 1 million new Medi-Cal visits in the last year. If we cut $1 billion more out of Medi-Cal rates, especially to the physician providers, I'm probably going to see 2 million more Medi-Cal patients coming in hospital emergency rooms. And it's going to cost the state more because it's more money to reimburse a hospital for an emergency room visit than a primary care physician for getting that care in the right place. So a big concern is the hospital emergency room and what that will do to exacerbate overcrowding that exists today.
I would assume that the progress we made regarding the Medi-Cal cuts that we've made in the last couple of budgets, I would assume that would get wiped away as a first step, which would probably, hurt the Medi-Cal program for a long time, because I think part of the reason that doctors are not volunteering to participate is that it's the unknown of where it's going to be, and if we have to go backwards after we were finally able to reverse some of the things that happened way back in 2009 and 2010, I think it would hurt the program going forward.
I think it would just really move us backwards. Especially in Medi-Cal, we're primarily fee for service, except for a few counties, Sacramento and LA, and so there's an even greater, I think, connection between rates and access there. And so if you cut the rates, you're going to see more and more providers dropping out. And I think what we've seen with our dentists is folks saying, okay, we're really glad that we got the 10% because now we can stay. And so I don't know that 10% is going to bring more providers back in, but I think we're going to be able to keep the ones that we have. And so any further cuts is really going to continue to decrease the number of providers who participate, the number of patients that they take. I think our members face a lot of the same issues that the doctors face, where you may be able to take a small handful of Medi-Cal, but if you continue to lose more and more money on it, you're going to be able to do less and less of that because you're subsidizing with your other patients. And we have the same issue with specialty dentists, that it's difficult for our general dentists who are taking substantial percentages of Medi-Cal. Maybe they work in a clinic. That's just the way their model is, that they don't have anyone to refer their patients to when they need a root canal or an extraction or other sort of more complicated dental procedures. So I think it'll just go in the opposite direction, and that kind of frightens me because we're already sort of already terrible. But that's the only way I see it going.
And the only comment I'll add, because I'm not in administration, but from a physician standpoint, I see that any time the system is burdened, everybody suffers. So it's you and your family as well as us on the panel and the people sitting behind me that will find a distinct decreased access to care when when the system is overburdened, where patients are not accessing care until later in the system, trickling downhill. So by the time the patients get to an obstetrician and have 16 problems to see, by the time they get to the emergency room and eat up all the services of an ER because they come in so complicated, that's physicians that are tied up with a complicated patient. They could be seeing another patient who's part of a managed care system, who's not Medi-Cal. So it hurts all of us when Medi-Cal is under-reimbursed. It hurts all of us. That's my point.
Dr. Wood.
First of all, I want to thank you, the panelists. I think I really appreciate your presentations. And having been a provider, a dental provider for almost 30 years, I get it, and a Medi-Cal provider for a very long time. Obviously, the cuts that happened in '09, in my opinion, really decimated our provider system, whether it's hospitals or physicians or dentists. And it's going to take time to rebuild that. So, as we look at funding, I applaud your interest in and moving forward on a tobacco tax. I think that's important. Obviously, the MCO tax is going to be really, really critical to us. But I just want to emphasize something that you brought up, and I think it's really critical for people to understand. When you're talking about rates, we're talking about rates to increase so that physicians and dentists and other providers don't lose as much money as they're losing now to serve the population. And that's really, really important. It's not that providers are trying to make a living out of this, because in the fee-for-service model in particular, you can't. It doesn't work that way. So it is about, we are already subsidizing care. It is about being able to subsidize care in a way that allows us to treat more patients and not in a way that limits our ability to do that. And so I think people need to understand, when you talk about rate increases, it's just they want to make more money. No, it's really we're trying to stabilize this to treat more patients and not lose more money and therefore burden the system anymore. And your emphasis on how this affects our care, or other people's care who are not on the Medi-Cal system, there, absolutely, you just hit the nail on the head. If you're going into a hospital that is already overburdened, trying to treat a population of patients that could be treated in another way, in a simpler way that is less expensive, and you need that critical care, and yet you have those basic preventive services, that access that you're losing is a critical part of this as well. So it does truly affect everybody. It is not just the Medi-Cal population. The more you overburden our system, the more people are affected, and it's not a positive effect, obviously. So I really thank you for your presentation and the clarity that you have brought to the message you've brought to us. Thank you.
Mr. Mace.
Is the proposed MCO tax the proper way of funding for these services? What's the proper way of funding for these services?
That's a very complicated question because there's not just one solution, I'm sure. If the MCO tax is not renewed, then we're way back to worse than 2009 in trying to bring more providers on board and trying to stabilize this unstable system. So at least the MCO tax has to be reinstituted. But beyond that, there have to be other sources like the tobacco tax, like other things I can't even imagine, that if I was a legislator, I hope I'd have the time and resources to come up with an imaginative other thing that in addition would help to fund Medi-Cal services. But the MCO tax is at minimum must have. And then beyond that, there must be other things.